I have no financial disclosures, and I would like to thank the Temple and Penn sonographers who collected these images over the years for me. I'm going to talk about the normal exam and specifically focus on extracardiac structures, common errors in view presentations. We're going to talk about the complete exam, but focus on the less common views and also normal variants. So in the parasternal long axis view, one of the common questions is this a pericardial effusion or a pleural effusion? The pericardial reflection is between the descending thoracic aorta and the left atrium. So a pericardial effusion will appear to go between these two structures. But the pleural space does not go between the left atrium and the descending thoracic aorta. And so a pleural effusion is always posterior to the side of the descending thoracic aorta. And you can see in this patient, they have a pericardial effusion anteriorly, so it's a circumferential pericardial effusion, and a little diastolic by the timing of the mitral valve RV collapse. So in the parasternal long axis view, you can see left and right pleural effusions, the aorta and the coronary sinus, and it's usually the right and non-coronary cusps of the aortic valve. The correct presentation of the parasternal long axis is with the apex horizontal, with the LVOT maximized. And looking at this image, we can see that we do not have, it's not a perfect view because the two cusps are not equal in size. The LVOT maximal dimension needs a little transducer rotation, and the apex is foreshortened. But I show this to remind you, again, the descending thoracic aorta. This is the AV groove, and that's the coronary sinus. So that's a mildly dilated coronary sinus. And looking at how large the RV is in this view, we would guess that it's dilated coronary sinus from right atrial hypertension. The other thing I want to point out in this structure is the right coronary the right coronary ostium that runs off here. And how do I know it's the right? Because the anterior leaflet in the aortic valve is always the right coronary cusp. This is in the right sinus of Valsalva, and this is the right side of the heart. Often much more difficult to see the left coronary from this view. So here's our first question. Take a look. Which of these following measurements are wrong? The diastolic measurement of the interventricular septum, the cavity, the posterior wall, or the aortic root? So A, B, C, or D. Don't vote yet. And now the questions are up. Go ahead and vote. So are A and C wrong, the septal and posterior wall measurements? D, the aortic root measurement? B, the cavity measurement itself? Just the LV measurements, but the aortic root measurement is right? Or are they all wrong? Luckily, the MBE is better at writing questions than this, and it won't be quite so confusing when you have to answer. Okay, so it was felt that the aortic root measurement was wrong, but in fact they're all wrong. And the reason is, if you look at this, this is systole, the aortic valve is open. So none of these diastolic measurements are correct. And this is a clip from one of our sonographers who had to be readjusted, that you can't, although you time systole and diastole by the movement of the mitral valve, you can't take as end diastole clip where the aortic valve is open. And if you look at the new aortic guidelines, which were published in JACE in January, the aortic root measurement should also occur at end diastole. So all of these measurements are incorrect. Now, Dr. Kane showed us this, and this is, if we did a blind M-mode measurement, this is where we would measure the LV. But this is the correct measurement. Below the tips of the mitral leaflets here, and you can see a big difference. The M-mode would get 4.9 centimeters, and the actual measurement is more like 4.4. In addition, if you measure from the short axis, you don't know that you're obliquely cutting the LV, and so the measurement should be from the LV, from the parasternal long axis, rather than the short axis. And you see here, in the same patient, we get 5.1 when we measure from the short axis, and so that's incorrect. Now, M-mode measurements must be made from the parasternal long axis and not from the short axis as well. They're conventionally measured from leading edge to leading edge, and you want to avoid including RV trabeculations in the interventricular septal measurements. The new chamber quantification guidelines were just updated in February, I think, of 2015, also published in JACE. Those are the measurements I would apply for the big exam, which is taking care of patients. But I doubt that any of the changes in quantification will be on the current NBE exam. It's a little too short a lead time. But these haven't changed. For chamber quantification, you want to minimize translational motion, maximize resolution, use a minimum depth necessary with the highest transducer frequency and the highest frame rate, avoid apical foreshortening, maximize endocardial border definition, and measure or pick the clip of end systole and end diastole by mitral valve motion and cavity size. These are the two guidelines that I refer to, published in January and February of this year in JACE for aortic imaging and chamber quantification. So the next question, which of the following measurements is recommended to be measured leading edge to leading edge? The LV internal dimension by 2D echo, the posterior wall measurement in diastole by 2D echo, the aortic root measurement from 2D, the left atrial measurement from 2D, or none of the above? Go ahead and answer. Okay, we have quite a splay, and the answer is actually 3. 32% of you got it correct. It's kind of a trick question. And can we go back to... I want to go back. All right, I'll use this. The remember I told you M-mode measurements are made from leading edge to leading edge, but 2D measurements are made from trailing edge, so trailing edge of the LV or at the endocardial blood junction to leading edge. So the convention's called trailing edge to leading edge. All 2D measurements should be made that way, except the measurement of the aortic root. And that's because the authors, Stephen Goldstein, first author who wrote the thoracic aortic imaging document, noted that all of the recommendations for comparing echo to CT, for when to operate, the measurements historically have been made leading edge to leading edge, and so they recommend that on 2D, the aortic root measurements still be done that way. Now, harmonic imaging takes advantage of naturally occurring harmonics to improve image. I'll leave it to Dr. Edelman to explain to you why and how it happens. But it decreases reverberation, haze, and side lobe artifacts. But structures may appear thicker and brighter when imaged with harmonics, and wall thickness and mass are slightly higher with harmonics on. Here's an example of a patient who has, this is with harmonics on and harmonics off. In patients with mitral stenosis, this can be pretty significant, and one paper showed that harmonics added 4 millimeters to the thickness of the mitral valve compared to with harmonic imaging off. So that's a key point when you're looking and trying to decide if a structure is normal or not. Other findings on the parasternal long axis, you can see a right pleural effusion as well. So let's just walk through this. Obviously, there's a very tiny pericardial effusion between the left atrium and the descending thoracic aorta. There's a left pleural effusion. This is the spine, and it appears rounded. You know it's the spine because there's complete shadowing behind it. Ultrasound just can't penetrate bone, so you know that's the spine. And on the other side of the spine, we see the right pleural space. So this is a right pleural effusion as well as a left pleural effusion. So this next question, the most serious abnormality in this patient is most likely, go ahead and answer, bicuspid aortic valve, mitral valve endocarditis, constrictive pericarditis, lymphoma, or carcinoma. Do they need to vote again? All right, I guess you can vote twice if you want. Okay, so 13% of you were correct. You've got to read the question carefully, which is the most serious abnormality in this patient. It's not advancing. No? Can we go back? Okay. And so you are right. This patient does have a bicuspid aortic valve, but it's not the most serious abnormality. There were redundant cords and not mitral valve endocarditis. Those of you who said constrictive pericarditis noticed that there's some thickening back here, which looks odd. But what you should see here is behind the left atrium a large mass also containing gas. And that's that high reflectile right here. And so this patient has esophageal carcinoma. There's air in the esophagus, and that's right where the esophagus is. I was sent a study just last week of a patient who had this bizarre mass behind the left atrium, but you could see that in the subcostal, it was a hiatal hernia and multiple loops of bowel in the posterior mediastinum. All right, now take a look at this. Don't vote yet. The ascending aorta is best imaged from this view by moving the transducer medially and to the right parasternal position, anterior angulation, one space cranially, laterally and caudally, or anterior and medial angulation. So think about it and go ahead and vote. That's great. The majority of you got it correct. The answer is one space cranially. And here's the question again. Medial and anterior angulation are going to bring you towards the right side in the pulmonary artery, which aren't going to help you. This is moving one space, one intercostal space cranially. You can see that here's the normal parasternal view, and you have to move up to be able to image the ascending aorta. You can't always see it quite as nicely. The sternum gets in the way in a lot of people, but this is the way to image it. Now let's talk about the right-sided views. We're going to talk about the RV inflow. Remember that the view is named for the position of the transducer and not what you see on the view. And I'll show you an example of why that's a little confusing. This is the parasternal RV inflow view. It's obtained by pointing medially and inferiorly from the parasternal long axis. And in this view, you usually see the posterior leaflet of the tricuspid valve and the anterior leaflet. You'll notice that this patient has carcinoid, a thickened and fixed valve. In all other views of the tricuspid valve, you see the septal and the anterior leaflets. This used to be a question or two on the boards because Ned Wayman was personally obsessed with the leaflets of the tricuspid valve, but I think they've moved on. Still is an important point. So here's the view done incorrectly. How do I know it's incorrect? Because this leaflet is attached to the interventricular septum, that's the septal leaflet. And so I asked my sonographer, in a case with endocarditis, you need to go back and take a look. I can't see the posterior leaflet in any other view. And here is it in the same patient, done correctly, requiring rotation. As we can see here, this is the inferior vena cava. This is the os of the coronary sinus, and you cannot see the superior vena cava os from the RV inflow view because you're pointing down and not up. This is the parasternal long axis view of the pulmonary valve. It's named for where the transducer is. It's obtained by medial and anterior angulation. You can see the zoom, the normal motion of the pulmonic valve with a good place to CPR, good place to measure gradients. And this is an M mode, which I show you only out of kindness that it might be on the exam. I think M mode is an outdated historical relic, but be that as it may. This is normal pulmonic valve opening. The diastolic pressure in the pulmonary artery is so low that normally the pulmonic valve moves towards the pulmonary artery after the A wave. Now I show you this clip and we'll let it play a couple of times. This is the pulmonary artery, the right and the left main branches. But as we pan, we also see here left atrium and the left atrial appendage. The left atrial appendage lies right over the pulmonary artery. And so you can have your text present views to you where you believe you're looking at the pulmonary artery and it's really the left atrial appendage. Here's the example from one of the ASC publications. And again, the left atrial appendage and the relationship with the pulmonary artery. Remember that the non-coronary cusp of the aortic valve is intersected by the interatrial septum. The right coronary cusp is always the most anterior, which leaves the left coronary cusp. And this is called the parasternal short axis view of the aortic valve. So next, we're going to skip this question because I realized I have the wrong answer. None of these answers are correct. But let's look at this. This is in the parasternal short axis view of the pulmonary artery. It's called short axis view of the pulmonary artery because it's the parasternal short axis view, but you see the pulmonary artery in long axis. This is the right pulmonary artery. This is the left, obviously the main. This is the ascending aorta just above the root, and this is the transverse sinus. So I had a bleak in there, I don't know why. We're going to skip that, okay. And the transverse pericardial sinuses are the potential space between the great vessels, whereas the oblique pericardial sinus is below that. So that was the transverse pericardial sinus. The oblique pericardial sinus is the one that fills with pericardial effusion that we see causing tamponade. Now, I want to point this out for several reasons. Number one, again, pulmonary artery, right pulmonary artery, left pulmonary artery. The pulmonary branches are not in exactly the same plane, and so you can not image them. Sometimes you can't see them. The descending aorta in this view is right here, but in this picture, the descending aorta is right here, and here is a very large PDA. In 2D, you can sometimes be fooled if a patient has a huge PDA that that you're actually looking at the left pulmonary artery. Why is this important? Here's a patient, I know the 2D is ugly, but the pulse above and below the pulmonic valve was normal, but look at this continuous wave Doppler across the pulmonary valve. It looks like the patient has pulmonic stenosis and has very weird continual flow into the pulmonary artery and diastole. And the reason is that the continuous wave Doppler is actually hitting the descending aorta, and here's the abdominal aorta in this patient. They have continuous color flow. They had a coarctation. And so the continuous wave Doppler was getting the coarctation flow in the descending thoracic aorta and not the pulmonary artery. The apical views are important for RV assessment. I think I've upset Dr. Cronzen because he likes M mode. And I will say that he is brilliant at M mode, as is Dr. Origema, and it's on the exam, so be careful. There's Doppler and apical 5-chamber views. So this question, take a look before you answer. In this dedicated RV view, one of these is not true. It's imaged by moving the transducer laterally from the apical 4. The RV may appear dilated despite normal size. Tissue Doppler measurements are most aligned. Highest RV pressure measured from this view. We want the one that's not true. Go ahead and answer. And so 41% of you got the one that's wrong, which was number 1. The dedicated RV view is obtained by moving the transducer. The transducer should be over here. Remember, the peak of the triangle is where the transducer is. So a regular 4-chamber view, the tip of the triangle is over here, and you have to move medially, not laterally, to get this dedicated RV view. The other 3 statements are correct. This is the correct 4-chamber view in the same patient, and you can see that the RV looked dilated but is completely normal in size. And so when we talk about RV measurements, we have to be sure whether we're doing RV dedicated or whether we're doing standard 4-chamber. All right, so take a look at this before you answer. The structure indicated by the arrow in this cropped apical four-chamber is, this is the RV, this is the RA, this is the tricuspid valve plane, this is the LV, and I want to know what this linear structure is. Chiari, coronary sinus, SVC, crista terminalis, or eustachian valve. Okay, go ahead and answer. Very good. It is a posteriorly directed transducer position, and we pick up the coronary sinus. And so here is the sweep, posterior to anterior. You see the coronary sinus here. The ostium comes right into the right atrium at this level, right below the tricuspid valve plane. As you saw in the RV inflow view, the structure that enters the RA closest to the tricuspid valve plane is the coronary sinus. So now let's talk about the eustachian valve. It's a ridge of tissue that in fetal life directs IVC blood to the fossa ovalis. All fetuses have patent foramen ovale. The IVC carries the most oxygenated blood from the placental circulation into the RA, and then the most oxygenated blood crosses into the LV, goes out the aorta into the head vessels. So every fetus starts with a eustachian valve, and Chiari network is also on the right side of the heart. But you need to distinguish it from eustachian valve. Chiari network has no known function. It's not present in every patient. It's a net-like structure that's highly mobile and may look like many strands. It usually arises from the vicinity of the IVC, but it is very rarely attached to the septum. Whereas the eustachian valve directs IVC flow across the fossa. It's present in every fetus, and it usually involutes, so it's not quite as obvious in adults. But sometimes it can be a big ridge of tissue, rarely mobile, and it arises from the IVC, runs across the floor of the right atrium, and attaches at the septum. So here is a Chiari network, a net-like structure fluttering around, and here from a subcostal view, IVC, a very prominent eustachian valve that you can see is directing the flow right towards the area of the fossa ovalis. So take a look before you answer. The abnormality in this case is, this is an apical four-chamber view, pericardial hematoma, descending aortic aneurysm, kyphoscoliosis, normal post-heart transplant, or an artifact. Okay, go ahead and answer. I fooled you. Let's go to the picture. This is a patient. This is the descending thoracic aorta, and this is the spine. This patient has kyphoscoliosis. Neither of these, whether you thought this was the aorta or this, neither of them are large. They both look normal, but this is what kyphoscoliosis looks like. Similarly, if you have a pectus excavatum, the RV can look very weird with a big bulge at the apex, and that's just from thoracic cavity abnormalities and not from any cardiac abnormality. Let's talk pulmonary veins. So this is from the back of the heart. This is the ascending aorta and arch. This is the SVC. This is the right pulmonary artery and the left pulmonary artery. And this is the left atrium with the left superior pulmonary vein and the right superior pulmonary vein. This is the axis of the apical 4 that cuts straight through into this picture to show you which veins we're imaging. So if we flip it around, you see the left superior pulmonary vein over here and the right superior pulmonary vein here. From transthoracic imaging, you can only see 3 pulmonary veins. So now look at this. This is the right pulmonary vein. I know because this is the right side of the heart. Here's the intraatrial septum. This, if you look, is not the left superior pulmonary vein. Take a look at it. It's only got systolic flow. It doesn't enter the left atrium. It's the descending thoracic aorta. But as we angle a little bit in this patient, we get this blue flow. We angle anteriorly. How do I know it's anteriorly? Because now I can see the aorta and the LVOT. And this is the left inferior pulmonary vein. So those are the only 3 that you can see on transthoracic. Now, for Doppler assessments, remember that for all diastology, you place the sample volume at the leaflet tips. The only time you put the sample volume at the mitral valve annulus is if you're doing a measurement of cardiac output using the mitral valve annular area. But usually, 99% of the time we don't do that, and the sample volume should be at the leaflet tips. You pulse along the septum to see if there's an LVOT gradient. You can pulse above and below the aortic valve. Now, they may ask you a question like this. What's wrong with this picture? And here's a patient who has tricuspid regurgitation, and you can see that the sonographer measured the peak velocity as 3.86, giving us a peak gradient of 60 millimeters of mercury, to which we would add the RA pressure. Clearly, that's crazy. First of all, she's measuring some haze down here and not the dominant. But this is me trying to measure the tricuspid valve velocity, and you can see I got gradients between 32 and 45. The problem with this is that the scale is incorrect. And what happened? This was taken with the same scale that they used for the mitral, for the MR continuous wave. They then just flipped the cursor over and took the TR. To fix this picture, you would raise the baseline and change the scale so that so that the peak velocity down here was more like 3.5 meters per second. The problem here is that any little change in where I'm measuring it propagates a very significant error because I'm squaring the measurement to get the gradient. And so this is just bad scale is the answer to what's wrong with this picture. Tricuspid annular plane systolic excursion, or TAPSE, we put the M mode cursor through the tricuspid annular plane and then measure the tricuspid excursion. 1.7 in the RV document published by ASE is the normal, is the lower limit of normal. And tissue Doppler, again, 10 centimeters per second is the lower limit of normal. You can measure the RV velocity, and this is helpful in cases where you're trying to decide the RV is dilated, but is the function normal or not. The apical long axis, remember that this is the inferior lateral wall, formerly known as the posterior wall, but no longer. And the anterior septum, how do I know it's the anterior septum? Because I can see the aorta. If I see the septum and I don't see the LVOT, it's the inferior septum. In the two-chamber view, the We're looking at the anterior wall and the inferior wall, and I show you this view to remind you that you can see the left atrial appendage in this view, the atrial prominence, and the left upper pulmonary vein. And then we can see a little consolidated effusion here behind the left atrium. This is in the chamber quantification document. You should know the coronary artery territories, and I hope it reproduced well enough. Certainly on the key drive it should, but you should know them. And the thing I like to point out is that the inferior, the RCA supplies the inferior septum at the base. And so this is the four-chamber view. This is the septum, and it's the inferior septum because I don't see the LVOT and aorta, but the base is always supplied by the RCA with variable distribution of other territories. Okay, let's talk subcostal. This is the subcostal four-chamber. It's the same plane as the apical four-chamber, but it's a very nice view to see the intraatrial septum, and you're perpendicular to flow, so it's the best place to look for an ASD or a PFO if you have a good view. The short axis of the subcostal, diaphragm, RV, left ventricle, this is aorta. Remember that the non-coronary cusp of the aortic valve is intersected by the intraatrial septum. So this is non, this is right, leaving this to be left. And it's right because the pulmonary artery is the most anterior structure in the heart. The right coronary cusp is the most anterior. So this must be the right coronary. And again, this has to be the non. The subcostal IVC assessment, I'm sure we'll talk about later, but here's a patient with a sniff. You can also put an M-mode cursor through it and see what happens to assess your CVP pressure. And I just show you this because the tech was kind of fooling around. You put color on this, you'll see all kinds of flow, and that's good because that's the kidney, and this, of course, the liver. Suprasternal notch, you need to know the anatomy. The first branch is the right brachiocephalic artery. The left common carotid and the left subclavian are not usually in the same plane. You don't usually see them all three at the same time. And this is the brachiocephalic vein runs across the top of the aortic arch, the descending aorta. It's the right pulmonary artery that goes under the aortic arch. And so that is the RPA. In this view called the crab view, you can see the brachiocephalic vein running into the SVC, the aortic arch in short axis, the RPA in long axis, and then you see the right superior pulmonary vein and the left superior pulmonary vein attaching to the left atrium. And so again, just the normal anatomy. I'm in the interest of time, I'm not going to ask you this question, but take a look. This is the short axis, this is the long axis of the aorta, so ascending aorta arch, descending aorta, and this is actually the bifurcation of the pulmonary artery. You're looking straight down the barrel of the pulmonary artery, and so the correct answer here is right main pulmonary artery. How do I know it's the right? Because this is the left side. The descending thoracic aorta goes down the left. This is the left PA, that's the right PA. Now let's turn to TEE. I recommend, for those of you who don't do TEE a lot, to take a look at this comprehensive TEE guidelines and standards that was published in 2013. It really has great views that let you look at the anatomy and know where the transducer is when you get each picture. And so I'm just going to go through a few things. This is the 4-chamber view obtained with the mid-esophagus. This is the lateral wall. This is the inferior septum. How do I know it's inferior? I don't see the aorta. This is the RV free wall. Posterior leaflet of the mitral valve, anterior leaflet of the mitral valve, coronary sinus here in the AV groove surrounded by fat. And obviously we can get color here. We can move the transducer a little, see the RV a little better, and this is at 0 degrees. This is the 2-chamber view, the anterior wall of the LV and the inferior wall. Again, the posterior leaflet of the mitral valve, the anterior leaflet, coronary sinus. This is the transgastric short axis view. Remember, anterior is now at the bottom of the picture, so this is the posterior medial papillary muscle, and this is a 2-headed anterolateral papillary muscle. You can go long axis from the transgastric to look at mitral valve apparatus, and you can go deep transgastric, which allows you advance the probe and then anteflex, and so you can take a really good look at the aortic valve. This is the best place to get gradients across the aortic valve, and you can also see the aortic mitral continuity if you're lucky, if you're looking at cases of endocarditis. Back to the mid-esophagus, we're looking at the aortic valve, interatrial septum, transex, the non-coronary cusp. Anterior in the TEE views is at the bottom, so this is the right, which leaves this to be the left. And again, the long axis is exactly the same view as the parasternal transthoracic long axis, but it's flipped, so the anterior coronary cusp is the right coronary cusp, and the posterior one is usually the non. We can do color flow from here. Now the mitral valve, and there are several good articles, but I like the Transesophageal document, and it shows you all the different views and what scallops you're looking at. And so I'm not going to ask you this question either, because Dr. Kane already asked you. Severe MR in this patient is due to, this is a modified apical 4-chamber view. This is the anterior leaflet, which looks okay, and this is the posterior leaflet. It is usually in this view P2 that we're looking at, so the answer is P2. You can see that it's actually even a little flail. The P2 prolapse and flail is directing severe MR anteriorly. But as Dr. Kane showed you, 3D is going to do away with all this complicated which leaflet is it, which view is it. This is again in the surgeon's view. This is the anterior, the aortic valve. This is the anterior leaflet, the posterior leaflet. And we can see that in the patient that I just showed you, the middle scallop of the mitral valve is prolapsing. So it is in fact P2. This is kind of a brain dead thing, but I could never remember where. I got that P2 and A2 were in the middle, but I could never remember whether P3 was medial or lateral until I heard a lecturer say, lateral looks like 1, and so P1 is lateral, and 3 looks like an M turned on its side, and so P3 is medial. And you won't believe how many times the fellows ask me a question, I have to say that to myself in my head, but if that helps you, I hope it does. Okay. Now, remember that the left atrial appendage has a number of lobes, so you have to look at it from a number of views. a number of omniplane views, and you have to roll through it to get all the lobes. And so here is left atrial appendage. Here is a little pericardial effusion in the transverse sinus. Here's the mitral valve plane. And so take a look at this before you answer. This is the left atrial appendage. The left atrial appendage in this patient contains mamelons, scapula, rugae, pectinate, or thrombus. Oh, great. That is correct. These are pectinate. They're not thrombi. Scapula actually means brush in Latin. There's nothing in the body, I think, named scapula, but it does look like a brush-like structure sticking up into the left atrium. And to remind you, these are mamelons. So if your dentist tells you you have nice mamelons, don't be offended. And this is from a deep transthoracic. These are rugae of the stomach. All right, so I'm not going to tell you what view this is. You can see that it is at 50 degrees. And the question is, what is this valve? Or aortic, mitral, pulmonic, tricuspid, or prosthetic? Take a look, and then we'll go to the next slide. Go ahead and answer. Very good. In this picture, the most anterior structure is at the bottom of the image, and the pulmonic valve and the pulmonic artery are the most anterior structures in the heart. Therefore, it has to be the pulmonic valve. This is the tricuspid valve. This is a portion of the mitral valve, and the aortic valve is out of plane. This is the bicaval view. The superior vena cava is here. The inferior vena cava is here. This is the right atrial appendage. It's usually broad. It's not very distinct in many patients. And this is the area where a PFO would be seen. Interestingly, you can kind of see in this patient that it's tacked down. So even though it's mobile, it doesn't look like this patient has a PFO. Here's another bicaval view, and often it's wise to lower the Nyquist limit so that you catch low velocity flow and look in the area where the PFO would be seen. In just off axis of the bicaval view, you can image the tricuspid valve. And this is where you align best with tricuspid regurgitation if you're forced to measure the PA pressure by TEE. This is a eustachian valve running on the floor of the RA. And again, the pulmonic valve at the bottom of the screen, a little PR, the aortic valve in almost short axis, and the tricuspid valve here. Now, in patients with chronic pulmonary embolic disease, this view can be very helpful. At 0 degrees in the mid-esophagus, you find the aortic root and withdraw slightly. You will see, this is the pulmonic valve here, this is the main PA, this is the right PA. It's very hard to see the left PA by TEE. And a PDA would come in right about here, so it can be very difficult. This is usually right about the level of the carina, where the airway passes between the esophagus and the aorta, and you often just can't see this area very well. If you move the probe, so if you just rotate the probe so that you move this image this way, you'll see more of the right pulmonary artery and often can see thrombi if they are in the main PA. And again, I want to emphasize that the left atrial appendage and the pulmonary artery are right next to each other. And you'll see this as you do TEEs. This is just rotating the probe, not omniplaning, not antiflexing, just rotating the probe from one side to the other to see the pulmonary artery and then the left atrial appendage. I noticed when I was going through my talk today that I had right pulmonary veins here, and so Dr. Teig saved me. These are left pulmonary veins. This is the left atrial appendage. We're at 0 degrees. We pull back and antiflex sharply. You can see that the left atrial appendage is filled with sludge and possibly a thrombus. And this is the atrial prominence, not so prominent because it's sludge lining it. And this is the left superior pulmonary vein. By inserting the probe a little and turning posteriorly, we see the right upper and the left upper and the left inferior pulmonary veins. And this is at 124 degrees. You can also get this in 0 degrees by the maneuver I mentioned. For the right pulmonary veins, you can see them at 45 degrees. You rotate the probe to the right, or you can go at 90 degrees from the bicaval view and rotate to the right. This is the right upper next to the SVC. This is the right lower. This is from a ASE publication. Right upper vein, right lower vein. Now the descending thoracic aorta, you can see this patient has a significant atherosclerotic disease. I don't recommend that you take long clips. It is convenient, but it really eats up space in your digital storage. So stick to clipping interesting things, or if the aorta is normal, clip a couple of still frames. You'll save yourself a lot of storage space. This is the descending thoracic aorta, this round thing here. It has an intra-aortic balloon pump in it. So in the descending thoracic aorta runs in the left side of the chest. So in this para-aortic gutter is a left pleural effusion. As we rotate the probe around and we don't see the aorta, this is the right side of the chest, and that's a large right pleural effusion. So I don't know if we've collected any questions.
We have.
Oh, good. All right. So this is the last set of images I'm going to show you. This is mid-esophageal views of the descending thoracic aorta in a patient, a different patient than the one I showed you before, with an intra-aortic balloon pump. So take a look at this. And now this still frame, 0 degrees, gotten by withdrawing a little more. And the final question is, the aortic balloon pump in this patient is too high, too low, just right, or that is not the balloon pump. Am I supposed to press something? Oh, okay. Correct. It is too high. If you can see, I'd like to go backwards. This is the aortic arch. And how do I know that? It's because it's at 0 degrees, and the aortic arch is laid out lengthwise. That is part of the intra-aortic balloon apparatus. And if you can see the intra-aortic balloon in any part of it in the arch, it's too high and needs to be pulled back. It's kind of an emergency if it's that high, right? And so that is the balloon pump, and it is way too high. With that, I will stop and answer any questions. Thanks for your attention.
Now, if any of you have any questions, the collector did collect a couple, but you can certainly bring them up if you'd like. Okay, the first question I'm afraid that Dr. Wiggers may not be able to answer. Can you please provide the precise reference for Dr. Feigenbaum's review of M-mode?
No, but we'll get it to you.
Yeah, we will.
As soon as I get on the internet.
Exactly. Another one. Very good. Second question. Can you please show us again what a leading edge to trailing edge is?
Can we go back to like the third slide in my presentation?
And the third question is similar. Leading to leading for the aortic root is confusing. Most centers have been doing trailing to leading.
I agree that most centers have been doing trailing to leading for the aortic root. The argument is that most of the literature measured M-mode measurements and related them to when to operate on aortic dilatation. In addition, CT measures the entire caliber of the aorta, which is more leading edge to leading edge, and so that's recommended. For 2D, leading edge, trailing edge to leading edge is just measure at the border between the blood and the endocardium. So that's the trailing edge, because the other side of the measurement would be the leading edge. So trailing edge is this side of this line, and leading edge is that side of this line. It's subtle, I agree, but the reason it's important is that M-mode measurements, since they're leading edge to leading edge, are always a little bigger than 2D measurements, which are trailing edge to leading edge.
Very good.
Okay.
And there's one more question that was for me, and that was, will you be providing the basically detailed answer key for the pre and post test? And if not, can you? I'll look into that. I definitely have a full post-test slideshow with explanations, etc. I obviously don't want to put it in the initial handout because that would give away the answers. But I will investigate whether or not this could be done in some electronic form or more or less likely a paper form. But I'll let you all know sometime in the next day or so.